Hey y'all, welcome to another ultrasound video from the POCUS students from the UC Davis School of Medicine. I'm Gabe.
And I'm Julia.
And we will be discussing the basics of soft tissue ultrasound.
For further material, you can refer to the free ebook Introduction to Bedside Ultrasound, which you can download on iTunes for free. You can also refer to the ACEP Soft Tissue Ultrasound Guidelines and the ACEP Emergency Ultrasound Imaging Criteria Compendium. These were the main resources that we used for this lecture.
Let's get to the first case. Your first patient of the day complains of bug bite. They got this localized area of pruritus, which is a fancy word for itching, edema, and erythema, and it's been growing in size. And they mentioned that something, maybe a spider, bit them. They didn't see it, but they say that's what happened. Poor spiders, they're always getting a bad rep when it comes to skin infections. Although they don't have a thermometer to keep their temperature, they have felt warmer than usual with some chills and sweating. Given the patient presentation and the symptoms on the top of your differential, you should be thinking that this is an abscess or cellulitis. But Julia, what can we do to improve our diagnostic accuracy here?
I'm going to go with ultrasound. So let's talk about the indications for a soft tissue ultrasound. The primary indications are potential cellulitis, abscess, or soft tissue foreign bodies. Extended indications include infections that might extend into deeper structures or removal of a foreign body that's identified. There are some times when you should avoid using POCUS for soft tissue. The contraindications include red flags such as pain out of proportion to exam, open wounds, or the need for immediate operative management. Ultrasound should not delay definitive management. There are also some limitations of ultrasound that you should be aware of. Ultrasound cannot replace your clinical judgment, so if your history and physical exam are not suggestive of a soft tissue infection, the ultrasound might not be of any additional value. Also, you should remember that the sensitivity and specificity of ultrasound for soft tissue is not 100%. According to this great article, it's more like 97% and 83% respectively. One good example of these limitations is something like an isodense abscess, which may appear like surrounding tissue on ultrasound, but if incised, would drain. We'll talk some more about what all these things look like on ultrasound, but first, let's go back to Gabe for a quick review.
Okay, real quick. For any soft tissue ultrasound, you'll use the linear array probe. This probe has a higher frequency and will maintain the resolution as you increase the depth, which makes it ideal for soft tissue structures. Make sure you're using copious jelly and remember the orientation of the indicator. To the patient's right on the transverse view or to the patient's head in the sagittal view. When you scan normal tissue, notice the structural organization of all tissues, including the epidermis on top, then the dermis, followed by the subcutaneous fat and the muscle striations and fascia. Now let's talk about the terminology used to describe the ultrasound findings. The majority of body fluids will appear anechoic, or without echoes, or black on screen. This is due to those sound waves passing through the fluid and not being reflected back to the probe. Some solid structures, organs, masses, purulent collections will be isoechoic, meaning that they will have the same echogenicity as their surrounding structures. Others will be hypoechoic, meaning that some shade of gray will be present but not distinctively bright. Lastly, anything that can reflect the majority of the ultrasound beams like bones, fibrous tissue, fascia, and even air will appear hyperechoic or bright on screen.
Alright, now that we have that primer, we can go back to our case. So remember our patient with a bug bite. We do an ultrasound and this is what we see. How is this useful? One of the main uses of soft tissue ultrasound is to distinguish between cellulitis and abscess. This is important because management is different and abscesses may need to be drained. Classic findings you can see in cellulitis include blurring and loss of normal tissue planes, which you can see early, and later you can see cobblestoning.
Julia, what is cobblestoning?
Well, cobblestoning is separation of the subcutaneous adipose tissue due to interstitial edema, leading to distortion of the skin layers. You can see cobblestoning in this clip here at the top of the screen. If you use your imagination, you can see that it looks a little bit like cobblestones in a path.
An abscess on ultrasound will show a discrete fluid collection, whether hypoechoic or isoechoic, with a spherical or elliptoid appearance. Depending on the content of the pocket and the age of the abscess, the echotexture can vary from purulent, more fluctuant material to more complex or fibrinous tissue that may look isoechoic. This very angry abscess has some visible septations, appearing as if loculated, and some heterogeneous echotextures. Make sure to always compress the abscess as you scan, and note for the swirl sign, which is an induced motion of the purulent material within the abscess. And lastly, always make sure to put color flow when examining for abscess, as you might see wall hyperemia due to increased blood flow to the site of the infection, which is normal, and to rule out any blood vessel involvement either near or within the abscess prior to draining it, as this will warrant a surgical consult. Keep in mind that not all elliptoid fluid collections are abscesses. Some of these abscess mimics include lymph nodes, malignant masses, abdominal wall hernias, and post-procedural hematomas. Note in this example you have an elliptoid collection of fluid, but you have the hyperechoic medullary sinus of the lymph node here with the surrounding hypoechoic cortex.
Alright, so after all that great information, let's go back to our case. So this patient presents with findings that are concerning for cellulitis versus abscess, so we use ultrasound. So if you see this, with classic loss of normal tissue planes and cobblestoning, it supports your diagnosis of cellulitis. However, if you ultrasound and see this, findings of cellulitis plus a discrete fluid collection, then your diagnosis shifts to abscess, which may require incision and drainage.
Nice, Julia. Great example of how an ultrasound can help direct management of soft tissue infections.
That's true. Ultrasound is a great tool, but we should remember that there are some caveats. For example, early in the infectious course, classic ultrasound findings may not be present. In addition, deep tissue infections may be difficult to ultrasound due to inadequate presentation with the linear transducer. This can also vary depending on the patient's body habitus. Abscesses also may have variable internal densities and consistencies, so sonographic appearance can vary, as we talked about with our isodense abscess before. You should also be cautious of patients presenting with cellulitis, as this can be indistinguishable from sterile edematous tissues, for example in a patient with lower extremity edema due to a cardiac cause. So in this case, the patient history should point you to the appropriate diagnosis and treatment, and ultrasound is only used as an adjunct.
Now on to the next case. This patient comes in complaining of foot pain that began yesterday while running barefoot outside. Pain is worse when they apply pressure to the area and when walking. Their exam is basically normal and you don't feel or see anything on their physical exam. So, this being an ultrasound podcast, let's ultrasound.
But before we reveal what we found in this case, let's talk about the basics of ultrasound and foreign bodies. Ultrasound is a great modality for investigating foreign bodies. It's actually better, meaning more sensitive than, X-ray for certain materials like wood, plastic, glass, or organic material like thorns, which may not appear on X-ray. As you might expect, larger objects are easier to see with ultrasound, but smaller objects, less than 2 millimeters, may be detected by the presence of an ultrasound artifact. One common type of artifact is called posterior acoustic shadowing, which is due to an object reflecting sound waves well, meaning that they don't travel as deep into the tissue underneath the object, and you end up with a hyperechoic object and a hypoechoic shadow below it. Sometimes, if the object is small, you may not see the object at all, and you see just the shadow. In this example of a splinter, you can see it casting a long shadow beneath it. Another common type of artifact is the ring down artifact, which is especially seen with metal foreign bodies. This is caused by a resonant vibration within fluid trapped within air. This ends up looking like a shadow, but instead has a series of repeating rings underneath the object. The last type of artifact we'll talk about is the halo artifact. This is created when there's surrounding edema or granulation tissue around the foreign body. This is usually seen when a foreign body has been in place for longer than 24 hours.
And lastly, recall that with everything, there are some caveats to ultrasound with foreign bodies. Small foreign bodies, as previously mentioned, less than 2 millimeters, may be difficult to detect and require more methodical examination. Foreign bodies adjacent to bones may be difficult to detect due to the hyperechoic shadowing from bones, but you can use the artifacts from the foreign body itself to help you detect if there's a presence of a foreign body. Other echogenic material in the skin like air, scar tissue, ossified cartilage, and keratin plugs can give you a false positive as well. And lastly, although ultrasound is sensitive for the presence of a foreign body, it's not 100%, so it cannot definitely rule out the presence of a foreign body. Lastly, foreign bodies within the digits or interspaces are very difficult to observe on ultrasound, but fortunately we have some tools of the trade like the water bath, which replaces the need for ultrasound gel or contact between the transducer and the patient's skin. This allows for better resolution, and the sonographer can rotate the transducer to obtain different images. You can also use standoff devices like a saline bag or a glove filled with water, as these can help you visualize the foreign body on the patient's digits.
Here's an example of a water bath in action. So you can see the water closest to the transducer with some bubbles in it, and then you can see a really clear outline of, in this case, a toe with some cellulitis. So this is an area that's normally pretty hard to access, and a water bath makes it much easier. So now let's apply all this knowledge to our case. So remember, we have a patient who presents with foot pain after running outside, and our exam is normal, so of course we're going to ultrasound them. So imagine we ultrasound and this is what we see. You can see a pretty convincing ring-down artifact, which I hope you remember means there might be a foreign body. So since this is a pretty specific finding, we're pretty confident to call foreign body in this case. But imagine you ultrasound and see this. There's actually nothing abnormal. This is a normal soft tissue ultrasound. So in this case, since we don't see anything, we can't definitively rule out a foreign body with ultrasound, so we might have to do something else diagnostically.
The final application that we'll briefly touch on is vascular access for blood draws. Make sure that when looking for veins with your ultrasound, that they are compressible and that you use the color function to determine the absence of pulsatile flow. Caveats: veins may appear like arteries the closer you are to the heart, like the internal jugular, and arteries may be compressible when farther away from the heart, like the radial artery at the wrist.
Here's an example using the carotid and internal jugular. You can see that as the probe is pressed down, the internal jugular collapses and the carotid artery does not. Here's some other examples of IJ vascular access for a central line in the transverse and longitudinal planes, and you can see the needle inside the vein. There are lots of great videos online that go through all the steps needed to use ultrasound to guide vascular access, and really the best way to learn is to practice yourself, so look forward to the hands-on workshop. Well, that's the end of our video. I hope you found it helpful.
We want to send a special thanks to our mentors, Dr. Schick and Dr. Medeiros, who helped us with all these projects, and to all the UC Davis Emergency Medicine residents for capturing these wonderful images that we used in these videos.
And since this is the end and we just graduated, we'd like to say good luck to the next Focus on POCUS students, Ivan, Aska, and JL. Good luck, everybody.